Now, there was one important trial called the Pioneer HF trial and Transition Heart Failure trial, which was done on ARNI in acutely decompensated heart failure patients and de novo heart failure patients. So those patients who came to hospital emergency with acute heart failure, whether they were acutely decompensated heart failure or de novo heart failure, these patients were actually enrolled and they were having a head-to-head comparison between enalapril and ARNI. So it has been found that actually ARNI gives a better safety profile compared to enalapril, with a lesser amount of patients going for drug withdrawal due to hyperkalemia or hypotension, and they have a better clinical outcome at even 6 months time. But while acutely decompensated patient can have a very volatile hemodynamic status during the initial days, so it was advised that these patients, when they are hemodynamically stable, that is, they have a systolic blood pressure of more than 100, they are off inotropic support, they are off the IV diuretic phase, then during the hospitalization phase itself, this ARNI was introduced. So in that way, this trial have shown us out the path to use ARNI in acute heart failure patients during the hospitalization phase itself. We have to only wait for the initial hemodynamic stabilization, that the blood pressure remains more than 100 or the patient remains clinically stable off the high dose of diuretic, and then we can start ARNI in this high risk group. So the question is that whether we can use ARNI in these acute heart failure patients or not. Yes, answer is yes. And should we use? Again, the answer is yes, because clinical benefit has been shown that if we can start ARNI in the pre-discharge level at the hospital during the first hospitalization itself, we can prevent further hospitalization, as well as we can have a better clinical outcome in this group of patients.